they can either drop, see there's a baseline if you will, they can drop massively, or they can more commonly elevate. Commonly call it S elevation infarct or non-S elevation infarct. So these kind of massive changes plus the right symptoms, that's an acute infarct. Right? However, as the infarct heals and so forth, the ST segment come back to normal, but the patient who had a tiny Q wave at the beginning tends to have an even wide Q wave. Okay? So this would be sort of tracing sit and on. So the QRS complex tells you a story. And you put that into the patient's medical condition and history. Okay, what's happening here? What's abnormal? ST depression in B4?
B4, B5, and B6.
On this one here?
Yeah.
Okay, so there's something different going on, right? If you would
It
have
could
to
just be
describe
a
it to somebody over the phone,
It could just be.
yeah, it's a PVC,
Because
right?
the rest of
If
them
you
are-
describe that over the phone to somebody, you don't make the diagnosis. Say, hey, I'm looking at EKG, and every now and then there is a early beat, right? Normal, normal, normal. The next beat should be somewhere here, but there's an early beat. And you say it's a PVC because the early beat is narrow or wide? It's wide, right? And we don't see a P wave in front of it. That's the T wave. So these are PVCs. And you're right, there are ST depressions, but on a PVC we don't really apply that. We expect to see that actually. We don't. How about here? Every now and then, early beat again, right? Darn it, it just happened. But what's the difference? The early beat looks the same as the regular beats. So that tells me the early beat takes the same path as the normal beat, which is down the AV node, down the ventricles during normal pattern. That tells me that these early beats are coming from the atrium. These are PACs. Everybody sees the difference, right? You get the early wide guys and the early narrow guys. PACs. What kind of symptoms might the patient have? None, right? War. You might say, hey, every now and then I feel like skipping. Palpitations, fluttering, butterflies, right? So these are the PACs, the extra beat is early. You have a P wave in front of the QRS, sometimes they're not easy to see. Now to make things even a little bit more complicated, again we have early guys, right? And we got early wide guys, they're wide. So maybe PVCs, but if you look carefully, and this is where the arrows point to, there is a P wave in front of the early guys. So they originate from the upper chamber, so they're not PVCs. They're not PVCs, they are coming from the atrium. But they're wide, they have a wide QRS because they're conducted with a bundle branch block pattern. It's called a Barron seam. You may have heard about that term. And the normal beat has a narrow QRS, but the early atrial beat has a bundle branch aberrancy because it travels through the electrical system early, and one of the bundles is not ready to accommodate that. So this is fairly common. So PACs typically have the same QRS complex as the normal conductive beat, have a P wave in front of it. Sometimes the PACs can be blocked. There's a premature beat. The normal sinus wave should be roughly here. There's a PAC coming in. It is blocked because the AV node says, hey, this is way too early. I cannot deal with that. You get a blocked PAC. Or like in the other case, the bundle branch says, no, this is way too early. I have to recover a little bit. And it gets conducted with a blocked bundle branch block pattern. Okay, PVCs come in different patterns, and people have done tons of research about they come in pairs and triplets. Here we call it what by general, right? Every other bead is a PVC. The PVC, what I often want to know is, do they all look the same, or do they look different in on different beads? Because if the PVC always looks the same, that tells me there's one specific focus or site inside the heart, which, if we choose to do so, we can actually track down with the ablation catheter and ablate. If the patient has multifocal PVCs, tells me, oh, there are at least 2 spots, that's going to be a long day with the catheter. Or maybe we don't do that. So, PVCs are very common, you see them all the time on telly. PACs are probably even more common on telly. Again, relates to underlying structural heart disease, high blood pressure, valve disease, etc., etc. Often they cause symptoms, not always. What's happening here? People winding down.
Flutter.
Ah, everybody knows flutter. Because of? The sawtooth pattern, right? It's actually a very nice example. Sometimes it's not as obvious. So, is the sinus node beating here? It's certainly not driving the action, right? Because the atrium is fluttering. In the background, the sinus node may be just doing this, but it cannot activate the atrium because the atrium is driven by the atrial flutter. And the atrial flutter is actually an electrical wave that runs rapidly around in the right atrium. Interesting effort. Obviously, it swaps over to the left atrium, swaps through the AV node and down to the ventricle. But the main problem is an electrical wavefront running in a circular fashion in the right atrium. And that circle that it takes is very predictable and repetitive in every patient. And this is why we can ablate atrial flutter very easily. It's very, very successful, low risk procedure. And atrial flutter can sometimes be very difficult to treat. Because normally people show up what? They have a heart rate of, in flutter, 150, right? Because in flutter, typically the atrium runs 300 beats a minute. And many AV nodes allow a 2-to-1 conduction. So your atrial rate is 300, your ventricular rate is 150. What do? We want a dope trick, right? Slow down the rate. We try to block the node and slow down the rate. And then what happens? Not much, but the pressure is down. So we're trying to deal with that. And here we have the big brother of atrial flutter, atrial fibrillation, right? Bane of cardiology of EP society. So tons of people have atrial fibrillation. Age increases the risk for AFib. 10% of folks over 75 have AFib. And that that population is growing, right? People get older. If you have hypertension, if you have valve disease, there may be a genetic component. Those are the things that drive the atrial fibrillation. So, unlike the atrial flutter, where the electricity runs rapidly in a circle in a very predictable fashion, atrial fibrillation is chaotic. I tell my patients, instead of 1 spark plug, the sinus node, you have 400 of them. And they go, oh my God. And they all fire off at the same time. So it gives you a complete chaotic atrial pattern, and this is why we see the wiggle line in the background. Again, the sinus node is trying, hey guys, 60, 70 beats a minute, but out there is chaos, right? Outside the sinus node. And the rate is fast and typically irregular. So we said, what's this? Flutter. What's unusual about this EKG?
It's a very slow rate.
It's a very slow rate, yes, right? There's a saying, typically in flutter, the rate is 150, we have to put them in Bill ties and so forth. So this is somebody who has atrial flutter and AV block at the same time, right? So the concept here is the thing, the atrium is in flutter, the flutter doesn't care whether you have AV block. For all intents and purposes, you don't have a ventricle if you have atrial flutter. It just runs. And if you have coexistent AV block, then you get a slow rate. Same down here with fibrillation, right?